Hi, welcome to the second video of daily essay drops. Today we'll be dealing with extraocular muscles. So this is one of the topics under the eye and orbit in the head and neck anatomy. So coming to the topic, initially the first step, we can divide the extraocular muscles into two. The one is voluntary muscles and the second one is involuntary muscles. The voluntary muscles are 7 in number and involuntary muscles are 3 in number. And the voluntary muscles can be again divided into two. The one that move the eyeball and the one that move the eyelid. Specifically the upper eyelid. And again, the ones that move the eyeball can be again divided into two. 4 recti muscles and 2 oblique muscles. And the 4 recti muscles are superior recti, rectus inferior rectus, medial rectus and lateral rectus. And the 2 oblique muscles are superior oblique and inferior oblique. And there is only one muscle that moves the upper eyelid, and that is levator palpebrae superioris, and we can call it LPS, levator palpebrae superioris. And the 3 involuntary muscles are superior tarsal, inferior tarsal and orbitalis. So this is the overview of all the muscles, all the extraocular muscles, voluntary, involuntary. Voluntary again to move eyeball and move the upper eyelid, and move the eyeball again into 4 recti and 2 oblique, and the one that moves the upper eyelid is levator palpebrae superioris. And we are learning about the voluntary muscles only. The 3 involuntary muscles, we just need to learn the name only. And coming to the second topic, we will be talking about the recti muscles in detail, and then the oblique muscles, and finally the superior levator palpebrae superioris. So this is a diagram we need while discussing it. So first going to the recti muscles. So as already mentioned, we have 4 recti muscles: superior rectus, inferior rectus, lateral rectus and medial rectus. So we'll be dealing with the origin of these muscles first. All these recti muscles originate from the corresponding margin of common tendinous ring. All recti muscles originate from the corresponding margin of common tendinous ring. CTR, it's a short form for common tendinous ring. So here we can see that. So this is the common tendinous ring. So you need to learn the diagram. So this is the common tendinous ring, and this is the superior rectus, inferior rectus, medial rectus and lateral rectus. So all of them are arising from the corresponding margin. So superior margin of common tendinous ring, superior rectus is arising from the inferior margin, inferior rectus is arising from the lateral margin, lateral rectus, and from the medial margin, medial rectus. So that is the origin of all the recti muscles. And there is an extra point that lateral recti muscle has 2 heads. And coming to the insertion, all the recti muscles insert into the sclera little posterior to limbus in front of equator of eyeball. So all the recti muscles insert into the sclera little posterior to the limbus in front of the equator of the eyeball. So here this is the eyeball, this is the cornea. And what is limbus? Limbus is the meeting, sclerocorneal junction is limbus. So this is the limbus. So all the recti muscles insert into the sclera a little posterior to the limbus. So this is superior rectus, medial rectus, lateral rectus and inferior rectus. And what is the distance from the limbus? So superior rectus is, medial rectus is 5, inferior rectus is 6, lateral rectus is 7 and superior rectus is 8 mm away from the limbus. So how do we remember the chord? There is a small mnemonic, like we can remember like mother is just like sister. Mother is just like sister. So M stands for medial rectus, I inferior rectus, L for lateral rectus and S for superior rectus, and that come in the order 5, 6, 7 and 8. So that is about the insertion of recti muscles. Coming to the oblique muscles, both the oblique muscles have a separate origin and insertion. So first is superior oblique. So superior oblique, origin and insertion. In the recti muscles, all of them had a common origin and a common insertion. But in oblique muscles, separate origin and separate insertion. So the origin of oblique muscle is from the body of sphenoid supromedial to the optic canal. So the origin of superior oblique can be seen in the above mentioned diagram as well. So this is the common tendinous ring. So supromedial to the common tendinous ring, we can see the origin of superior oblique muscle, and it is from the body of sphenoid. And coming to the insertion. Superior oblique muscle is also inserted into the sclera, but here the difference is, here it is inserted behind the equator, whereas the recti muscles were inserted in front of the equator. So here also it is inserted in the sclera, but behind the equator in the postero-superior quadrant of eyeball, behind lateral rectus and superior rectus. So that can be explained through a diagram. So this is an eyeball. Sorry, it's not behind, between. So again, this is superior rectus. Okay, here it's mentioned that it is inserted behind the equator, so it's a posterior view, and therefore this is lateral rectus and not the medial rectus. In the above diagram, here also it was medial rectus. In this diagram also this is medial rectus, but in the last this diagram, this is lateral rectus. This is superior rectus, inferior rectus, and here we have the medial rectus. And the superior oblique muscle is inserted into the postero-superior quadrant between the superior rectus and lateral rectus. So this is the insertion of oblique muscles. So we completed the origin and insertion of superior oblique. Coming to the inferior oblique. So the inferior oblique muscle has an origin from the rough impression in the anteromedial angle of the floor of the orbit lateral to the lacrimal groove. So this has to be learned by heart itself. No diagram can represent this. So it is originating from a rough impression in the anteromedial angle of the floor of orbit lateral to the lacrimal groove. So this was our common diagram of origin. So here this is the inferior oblique muscle. This is the inferior oblique muscle. So it is not originating from anywhere near the orbital apparatus. So it is originating from a rough impression in the anteromedial angle of the floor of orbit. Okay, it's from the floor of orbit, not from the common tendinous ring or anywhere near the optic canal. So we can represent the insertion of the inferior oblique muscle in the same diagram as well. So it is inserting into the, just like the superior oblique muscle, this is also inserting into the sclera. Similarly, behind the equator, again in the posterior superior quadrant, not different. Here it is a little below the superior oblique. That is the only difference. So here, this is the insertion of superior oblique muscle. Now, the lateral, inferior oblique muscle is inserted into a little below. Here is the insertion of inferior oblique. Now coming to the muscle that was used to elevate the upper eyelid. So that is levator palpebrae superioris. As I have already mentioned, we will be discussing about the voluntary muscles as well, voluntary muscles only. So we had 7 voluntary muscles, out of which 4 were recti muscles. Already the origin and insertion of the recti muscles are discussed, and we had 2 oblique muscles. The origin of insertion of the oblique muscles as well is discussed, and the last is levator palpebrae superioris. So coming to the origin, it is originating from the under surface of lesser wing of sphenoid. At the apex of orbit. The diagram doesn't represent the origin of LPS, and the insertion is, there are 3 insertions for levator palpebrae superioris, because levator palpebrae superioris has 3 lamellae. One superior lamellae, and the superior lamellae is the skeletal muscle part that is inserting into the skin of upper eyelid. And the intermediate lamellae, this is the smooth muscle part that is inserting into the upper border of superior tarsal plate. And the third part, that is lower lamellae, it is made up of connective tissue. It is inserting into superior fornix of conjunctiva. So that's all about the origin and insertion of all the muscles. So we had recti muscles, the oblique muscles. So this diagram represents the insertion of the oblique muscles, whereas this diagram represents the insertion of the recti muscles. And then we had the levator palpebrae superioris. And now coming to the nerve supply of all the muscles. So nerve supply of the voluntary muscles can be divided into 1 that move the eyeball and levator palpebrae superioris. So this is the nerve supply. So here all the muscles that move the eyeball except lateral rectus and superior oblique are supplied by oculomotor nerve. So oculomotor nerve, that is cranial nerve 3, supplies all the muscles that move the eyeball except lateral rectus and superior oblique, and they are supplied by, we can remember by mnemonic LR6SO4, because this LR6 stands for abducent, 6th cranial nerve, abducent nerve, and 4 for 4th cranial nerve, that is trochlear nerve. So LR6SO4, lateral rectus by 6th nerve, superior oblique by 4th nerve, all other nerves by oculomotor, all other muscles by oculomotor nerve. And this levator palpebrae superioris is supplied by two nervous systems. So one is the skeletal muscle part and the other one is the smooth muscle part. As already mentioned, it has 3 lamellae, and the first and the second lamellae, the superior lamellae is skeletal muscle and the intermediate lamellae is smooth muscles, and the skeletal muscle part is supplied by the upper division of oculomotor nerve, and the smooth muscle part is supplied by ganglionic sympathetic fibers, postganglionic sympathetic fibers. So this is the nerve supply. Oculomotor nerve supply all the muscles that move the eyeball, and LPS is supplied by upper division of oculomotor nerve mainly, and the smooth muscle part is supplied by postganglionic sympathetic fibers. And remember the mnemonic LR6SO4 because that is the exception. And now coming to the actions. So the action there are can be divided into elevation and depression, abduction, adduction, then rotation. Rotation itself is intorsion and extorsion. To remember the direction of action, we can represent it through a diagram. So if this is a nose and this is an eyeball, let's imagine. This is elevation and this is depression. This is adduction and this is abduction. And clockwise direction is intorsion and anti-clockwise is extorsion. Okay. Now coming to the action of muscles, individual muscles, we can remember this diagram. That is, again this is an eyeball. This is superior rectus, third inferior rectus. This is medial rectus and this is lateral rectus, and this is inferior oblique and this is superior oblique. So there is a change in the direction. Inferior oblique is on the upper side and the superior oblique is on the lower side. So remember that. So we can take the actions of each muscle one by one. So superior rectus, above RMF, so elevation, this is the nose, so towards the nose, so adduction, and the arrow is clockwise, intorsion. Medial rectus, only one action, that is adduction. inferior rectus, downward arrow, so depression towards the nose, adduction, and anti-clockwise arrow, so extorsion. Lateral rectus, only one direction, that is abduction. Superior oblique, downward arrow, so depression to the left, away from the nose, so abduction, and it's a clockwise arrow, so intorsion. Inferior oblique, elevation, away from the nose, abduction, and anti-clockwise, so extorsion. So again, elevation, abduction, extorsion. So this is the action of each muscle. So we can learn this from the diagram. Coming to the last topic of this extraocular muscles, that is the clinical correlation, which is very important. So the first clinical correlation is about strabismus or squint. The strabismus or squint means deviation of eye to the opposite side. So it is basically the deviation of eye to opposite side, and it is due to the paralysis of an individual muscle due to involvement of nerve. So this is explained as the paralysis of an individual muscle due to involvement of nerve, and that is leading to strabismus or squint, and that can result in diplopia or double vision. So strabismus can lead to diplopia, and if lateral rectus is paralyzed, already remember LRS is SO4, so here it is the abducent nerve involved. Squint will be medial squint, just the opposite direction, lateral, medial. And if medial rectus is paralyzed, it is because of the involvement of oculomotor nerve, and it will produce lateral squint. And the second clinical correlation is with the paralysis of levator palpebrae superioris. So that can be again divided to involvement of oculomotor nerve, which supply the skeletal muscle part, or due to the involvement of cervical sympathetic chain. As seen in Horner's syndrome. So both of this can cause the paralysis of LPS, and if it is due to the involvement of oculomotor nerve, then it causes complete ptosis. The eyelid cannot be elevated at all, so it causes complete ptosis or drooping of eyelid. What is ptosis? Drooping of eyelid. And if it is a lesion in the cervical sympathetic chain, that is not the oculomotor nerve, if oculomotor nerve is involved, it causes partial ptosis only, because this is not supplying the skeletal muscle. So that is about the clinical correlation, and that is all about the topic. So we discussed the classification of the muscles, and then we went to the origin of individual muscles, all the recti muscles, oblique muscles, and then levator palpebrae superioris, and then we went to the nerve supply, and then finally to the action. And I missed the action of levator palpebrae superioris. It is already understood. It is to elevate the eyelid. And then we went to the clinical correlation. Okay, thank you. That's all about the class, and I was Licsa Mariam from 67th batch, and thank you for listening.